talking to me. I might have been about 4.
Mm-hmm.
I didn't know it was him at the time, of course,
Mm-hmm.
but I just realized that. When I got older, I think he started to think of me as a defense minister or an advisor.
Severe psychiatric illness is not rare in children under the age of 18. In the pediatric population, underdiagnosis and misdiagnosis are disturbingly frequent. The good news is that we have new treatments, both medication and psychosocial, that offer tremendous hope for this population. Thank you for joining us for Child, Adolescent, and Young Adult Syndromes. Which clinical dimensions do atypical antipsychotics treat? I'm your host, Dr. Bill Glazer, and we're live and interactive on January 24th, 2001. And this is our first PyschLINK of the year with a brand new introduction that you saw. Whether you're watching on TV or on the internet, we look forward to your participation later on in the program. Now, I'm joined in our Dallas studios today by Dr. Charles Schultz and Dr. Sharon Camo. Dr. Schultz is professor and head of the Department of Psychiatry and acting head of neurology at the University of Minnesota Medical School in Minneapolis. And you may remember him from previous PyschLINKs. Chuck, it's good to have you back.
Well, Bill, thanks very much. It's nice to be back. And I'd like to also thank Dr. Kathy Daly, who did such a nice job on the introduction tape of a young patient with a psychotic disorder.
Right. We'll talk about him a little bit later.
Right.
But also congratulations to your venture off into the area of neurology. You're acting chairman of neurology at the University of Minnesota as well.
Well, Bill, I've been doing that for about the last half year now, and it's really brought up a number of very exciting educational opportunities between the two departments.
Good. Excellent. Glad to see that.
Anyway, thanks for having me back.
Good. And Sharon, this is your first time here. It's good to have you here on PyschLINK. Dr. Camo is a pediatric and adult psychiatrist in private practice and attending physician at Davis Medical Center in Statesville, North Carolina. Welcome.
Thank you. It's great to be here.
Good. Now, you're in private practice in the Charlotte, North Carolina area. You're seeing a lot of kids, a lot of adolescent patients. Talk to us about psychosis in children and adolescents. How do you approach this as a practitioner?
Well, first of all, Bill, let me state that psychosis in children does exist. Childhood schizophrenia is diagnosed as adult schizophrenia is. Children do have the positive symptoms of schizophrenia as well as the negative symptoms. As a child psychiatrist, we're very careful to rule out other disorders such as major depressive disorder with psychotic features, severe ODD, OCD, Asperger's disorder, and bipolar disorder with psychotic features.
Well, it's certainly good to have you because we have, I think, this topic of psychiatric disorders in children and adolescents has been one of the most requested topics that we've had over a period of time here at PyschLINK. So I'm very glad that you could join us and look forward to your input. Chuck, tell me, let's talk about schizophrenia. And your area is particularly focused in adolescents. When does schizophrenia start in adolescence?
Well, I think I might like to start, Bill, by making a transition from the tape. When schizophrenia begins in adolescence, the symptoms are similar to those seen as adults, and we use the same diagnostic criteria. However, I think many people still feel that adolescent schizophrenia might be a rare disorder. And as we can see from the graphic about the cumulative percentage for age of onset, I've modified this from a study Dr. Loringer did at Cornell, and he was looking at first episode patients who came to Cornell for the treatment of schizophrenia, wanted to know when was the onset and did males have earlier onset than females. You know what we see from this slide, if we go down to the age interval 10 to 19, nearly 40% of the young men in the study had onset of psychosis prior to age 19. This is not a rare problem. In addition to what we see on this slide about age of onset when first treatment began when people were first hospitalized. It's been our impression that the duration of untreated psychosis in teenagers can be a year or longer. Not just the prodrome, not just that maybe somewhat ill-defined period of time, but voices, delusions, thought disorder can go on for a substantial time before treatment has begun.
Right, so, and we know the longer that goes on without being treated, then probably the worse the course is going to be.
You know, there are a number of studies that show that. There are some studies that don't necessarily replicate that, but is not necessarily a reason to wait to initiate treatment and get going.
Chuck, what are the best data that may help us characterize the pathophysiology now in childhood schizophrenia? What's your best guess about that?
Well, you know, I think there are some groups, certainly the intramural program at NIMH, the group I worked with at Case Western Reserve University, that took tools for examining adult schizophrenia and brought them back a decade or more. Mm-hmm. I'd like to show for an illustration of this strategy a study that Dr. Lee Friedman and our group published this last 1999 in Biological Psychiatry. We decided to take the MRI studies and to examine the morphometrics, or the brain structure, in teenagers suffering from schizophrenia. Then we took a look at community controls and to also young bipolar patients. We wanted to see whether measurements of brain size, the shape and size of the cortex, was specific to schizophrenia, or whether it involved all youngsters with serious psychiatric illness. And as you can see from this graphic, Dr. Friedman and our group demonstrated that the patients with schizophrenia and with bipolar illness had abnormalities in the cortex and in their brain size. These findings indicate to us that schizophrenia in teenage years is the same as is seen in adults, is part of the same illness, and, if you will, really extends the neurodevelopmental hypothesis about schizophrenia.
Well, that's interesting, Chuck. Are there neuropsychological data that support those MRI findings?
Well, you know, when we started doing these MRI studies, we were beginning to think that just measuring the size of the brain or some of the structures was only part of the picture. And so we decided to also look at how the brain's working. Dr. John Kenny and our group designed this battery to assess youngsters, and you can see we're moving from personality psychological testing about how the brain works to cognitive measures. And here we see that we tested attention by doing the Stroop and the digit span. We looked at working memory, verbal memory, executive function, and as well as an estimate of IQ. You know, if we go to the next slide, we see the results of this work. And the way that Dr. Kenny has portrayed the results of our study with adolescents with schizophrenia and bipolars is the green dots along the top are the results of the normals. And then the Z-score are standard deviation units below normal. The sort of oranges, light orange color triangles are the young people with schizophrenia, and there's 21 in this group. And the reddish orange is the bipolar youngsters, and we had 12 of them, 8 of whom also had psychotic symptoms with their bipolar illness. What we found in this study is that already during adolescence, brain is not working so well for these people, especially in the area of sustained attention and memory. We've decided that this sort of data could be interested in clinical application, and so we started using neuropsychological testing in teenagers to assist us in treatment planning. It doesn't make any sense to have a youngster at a very low percentile of sustained attention go back to school and sit in a 50-minute class. And so we work with schools, we work with parents, and integrate some of this cognitive testing to help us figure out what can lead to the best outcome for teens.
That's excellent. So you set up your treatment plan based on neuropsychological findings.
Correct.
Very, very helpful. You find yourself doing that in your practice? Mm-hmm. Good, good. How severe is psychosis in teenagers, Chuck?
Well, at this point, I'd have to say that the outcome studies are not promising. Outcome of childhood onset schizophrenia and adolescent schizophrenia in the few studies that have been done show the outcome to be somewhat poor. In examining these studies, though, the questions I have Is adolescent schizophrenia characterized by such gradual onset that we have a very long duration of untreated psychosis? So is it that the disease is a bad disease with early onset, or are we just not able to get started with treatment early on? But this should be, psychosis in a teen, in my impression, should be taken very, very seriously. It's a severe disorder.
So does it respond to treatment as well as it does in adults? How could you characterize it compared to adults?
Well, you probably get the idea that I've mentioned duration of untreated psychosis. Let's get going. Let's get started with treatment. And in the past, as we can see on this graphic, if I were to say, hey, let's get going with treatment here in these teenagers, this is a slide taken from Keefe and colleagues at University of Oregon, Dan Casey's research group. On the far left side, you see the 10 to 19-year-olds in a study of extrapyramidal syndromes starting an antipsychotic medication. If a youngster started on a traditional antipsychotic medication as a teen, has about a 65 or 70% chance of having a dystonic episode, which is certainly a very bad start with that patient, and generally a bad start with their family. You know, you and I have talked, we can diminish the possibility of dystonia, but it means also adding other medicines like anticholinergic medicines that have their own problems. Teenagers find blurred vision, constipation, other side effects of the anticholinergics also pretty troubling.
So that really kind of gets us to the topic of our show today, which is the atypical antipsychotics. You're kind of, I think, implying here there's a real role for the atypical antipsychotics with that kind of a picture in children, younger patients.
Well, I'd say more than implying. And let me maybe move now to the results of a study done utilizing risperidone. Steve Gersovich on the clinical faculty of Case Western Reserve University has a very large practice for child and adolescent psychiatry, collaborated with the department, and reported on this 16-person case series with risperidone. This was in the early days of risperidone coming out, and Dr. Gersovich pushed the dose up as had been recommended. Yet we see very nice reductions of symptoms on this graphic. For the total brief psychiatric rating scale score, there's a substantial drop in symptoms. The clusters of symptoms from brief psychiatric rating scale that compile the negative symptoms were also reduced, and importantly, the clinical global impression also went down. Importantly for me, one of the youngsters was in this study was also in the MRI study, and I remember interviewing him one day, and he was leaving the interview room, and he said to me, "Boy, I'm really glad I'm on this new medicine." And I thought to myself, I had never in my career had a youngster say, "Thanks for the Haldol." The acceptability of the new medicines, to me, is just as important as their ability to reduce symptoms.
Good. That's risperidone. Anything with olanzapine?
Well, you know, olanzapine was the second of the frontline atypicals to come out, and Bob Finling and I designed a case series. We aim to enroll 20 teenagers who suffer from schizophrenia in this study, and we're most of the way through. Dr. Finling will be reporting on really the full complement of youngsters at meetings this spring.
Good.
You know, what we've seen so far is that olanzapine is well accepted in youngsters, teenagers with schizophrenia. Symptoms are reduced, similar to what we saw in the risperidone slide, and there is also reduction of negative symptoms. Medicine is well accepted in youth. Our biggest surprise, though, we were concerned about side effects, and we found that youngsters taking olanzapine do need to move up into the average dose of about 15 milligrams for successful treatment.
Oh, okay, interesting. So the dosing for the adolescent patient is very much like what we think about in adult patients.
Correct, especially at this acute phase.
Okay. Now, Sharon, Chuck's been talking about adolescent patients. What about studies in younger kids? What do we have there?
There was a study done by Dr. Sholovar at Temple University with hospitalized youths aged 6 to 13 years old. These children were given 2.5 milligrams of olanzapine initially, and then that was increased to 5 milligram after 5 days. No children had to be removed from the study secondary to side effects. and the effectiveness was evaluated using the 0 to 3 Likert scale. And as you can see from the next slide, 13 out of 15 of those children improved.
Those are the pluses.
Yes, that you
And
see.
1 plus is improvement, 2 is even better, and 3
is greatly
the best.
improved, the best. The only adverse effect that was noted was sedation, but actually after the sedation wore off, these children actually got better.
I mean, you know, this is the beginning of studies, but this is very impressive to me, and I think very hopeful. Don't you think about the effect of these drugs in children?
I think especially, you asked me earlier about severity of childhood and adolescent onset schizophrenia, so this is a probably particularly difficult group to treat, and to see 5 of the people get 3+ in their response is encouraging.
It's robust.
Yeah.
Good.
Yeah.
Good to see. Now that was a study of olanzapine. Anything with quetiapine?
Well, you know, quetiapine's the third of the frontline atypicals to come out, and to assess quetiapine's impact on psychosis in adolescents, Brian McConville at the University of Cincinnati designed a study to look at quetiapine in a broad range of doses. Actually, these young people had doses up to 800 milligrams during the trial. BPRS scores were reduced substantially by the 3rd week of treatment, and negative symptoms also went down. EPS was not noted, and the pharmacokinetic results showed that teenagers are handling quetiapine in a fashion similar to that seen in adults. They're not accumulating the medication, nor are they chewing the drug up, so dosing strategies will probably be the same for psychotic teens.
Okay. And just to clarify, Sharon's reports of the studies in children are showing lower doses compared to the studies you've been talking to us in adolescents. So the children are coming out pretty clearly when you're using atypical antipsychotics with lower doses.
Yes, we start them at the lowest dose possible and then go up.
Mm-hmm.
I might just insert, Bill, that since our study with risperidone, where we ran the dose up to 6 milligrams, which had been the early recommendation, we now know the average dose for adults is lower than that. And my clinical practice with teens with schizophrenia is to start slow, titrate up slowly, and I'm generally ending up at about 3 milligrams of risperidone in adolescent schizophrenic patients.
Okay. And Sharon, how about with olanzapine in your practice? What kind of a target dose do you usually end up with?
2.5, and then generally it stays at 5.
Okay, so
I really have to go up to 10 in a young child.
How about a teenager? Do you have teenagers with schizophrenia that you treat with olanzapine?
Yes, I do, and I generally treat them more in the range of the adult doses. But I start slow and then again work up, and I work up pretty quickly to about 10 to 15 milligrams.
Okay, good. Well, now let's venture away from schizophrenia and let's start talking about some of the other conditions which, Sharon, you are an expert in as a child psychiatrist. You mentioned earlier, you commented on PDD and Asperger's. Tell us more specifically about those conditions.
Well, pervasive developmental disorder actually includes 5 diagnoses: autism, Rett's disorder, childhood disintegrative disorder, Asperger's disorder, and PDD-NOS. Autism is the model on which all of the rest are based. These children are unable to engage with others. They treat others as if they were objects, and they do not have any social cues. They do not know how to understand social cues. With Rett's disorder, that's generally in females. It is pretty rare. It starts off with a child with normal development, and then between the age of 5 months and 4 years old, these children generally have a decline in their socialization and motor skills. Childhood disintegrative disorder is rare. There's a normal period followed by a rapid decline in socialization and motor function from the age of 2 to 4. Asperger's disorder is these children actually experience normal cognitive development. They have normal language, but they're deficient in social interaction, gestures, and facial expressions. And PDD-NOS is an atypical autism, sometimes called subthreshold autistic disorder.
What's in your practice, what's the most common of those 5 that you might run into?
Autism.
Autism.
Generally autism.
Okay.
Yeah.
Okay. Chuck, what do we know about the treatment for autism?
Well, the treatment for autism, there have been many hopes not always replicated. And I think my experience in over 25 years in this field is that there will be a new medication that will be developed and tested, or a new thought or hope about what can treat autism. What I'd like to turn to is the use of the new atypical agents in autism, but not holding out that these are medications that treat the illness autism. And I think Sharon did a nice job of telling us about these disorders. But you know, in addition to the diagnostic criteria of language development and treating people as if they were objects, autistic young people also can have aggressive behavior, substantial nervousness that borders on panic or worse, and these symptoms are among the most troublesome for families and institutions to handle. To address some of these behavioral disorders, again, Bob Findling at Case Western did a single-blind study with Dr. Wisnitzer in the pediatric clinic, children, adolescents, and some young adults, and found a substantial reduction in the behavioral symptoms that I've been talking about. To follow through on these, Chris McDougall, the University of Indiana, has conducted a double-blind placebo-controlled study looking at risperidone. And as you can see from this graphic, there is a reduction in nervousness, aggression, and other behaviors and feelings that young people with autism have.
That's, I think, in the next graphic, or is it that you were going to show those results, Chuck?
You know, I think we're going to talk about some of the other medicines in our next slide. And so I think I might just conclude by saying that in looking at problem behaviors in autistic youngsters and aiming at how we can maybe make some advances in symptomatic reduction, this data from risperidone would indicate that the atypicals may have some promise in this area.
Okay, excellent.
And then I think you were going to maybe think about some of the other atypicals as well.
like olanzapine.
Sure.
Sharon, you were going to comment on olanzapine.
There is one study by Dr. Malone. It's actually a head-to-head study using olanzapine versus haloperidol. This is a 7-week open-label study with 12 children. The mean age is 7.8. And the results showed that there is a symptom reduction in both groups. And the next slide, you can see that the olanzapine group is actually shows significant improvement in autism. The side effects were only drowsiness and weight gain with the olanzapine group. And I think if we show the next slide, you'll be able to see how olanzapine scored versus haloperidol. And as we've said before, olanzapine is generally very well tolerated.
And this is a condition, autism, that is, as you're saying, Chuck, is hard to treat. So we're seeing vitamin therapies and many other reports of different kinds of treatments that we don't often think of, alternative treatments, if you will. So this is good to see, because using the typical antipsychotics in this population, I know from my experience working with the Department of Mental Retardation clinically, where we see many of these patients, the typicals are a problem. So this is very good to see the efficacy that you're showing here from this study.
You know, one thing that Sharon showed on that previous slide that I have heard from child and adolescent clinicians is the substantial reduction of aggression and uncooperativeness, so that the atypical agents, seeing as we're talking about the spectrum of treatment of these new medicines, are not just targeting in on psychosis or mild psychosis, but you see anger and uncooperativeness and hyperactivity to be substantially reduced by olanzapine in this study.
Yes, and that actually leads to the next question that I wanted to get to with you, Sharon, was we've been talking about the use of the atypical antipsychotic agents in the psychotic conditions as well as PDD. And given this, the efficacy that we're observing, and what I think is a fairly clear, safer side effect profile with the newer antipsychotics, are you using them in other conditions for children?
Yes, I am, Bill, but before I get to that, I would like to describe some of the conditions that I do treat with the atypicals. I've grouped them under the title Disruptive Behavior Disorders. Under these disorders is bipolar disorder, attention deficit hyperactivity disorder, or attention deficit disorder, oppositional defiant disorder, and conduct disorder. These group of symptoms all have inattention, impulsivity, and angry outbursts as part of their symptomatology. And what happens is there's a diagnostic overlap that occurs, and it leads to the diagnosis of bad ADHD. So many times these children are seen first by their family practitioner or pediatrician, and they're diagnosed with ADHD and placed on stimulants. And a lot of times this can be a problem.
So it's an overdiagnosis
yes,
going on.
Actually, yes.
Okay. Well, let's try and sort this out a little more carefully then. You mentioned conduct disorder. How do you make that diagnosis?
Conduct disorder is unique in that these children have a repetitive and persistent pattern of behavior in which they absolutely ignore the basic rights of others. They appear not to have a conscience. They show no remorse for their behavior. And this behavior could be criminal. Destruction of property, lying, truancy, running away from home, fire setting. And as I said, specifically, they do not show remorse. They'll be upset if they get caught, but they're afraid for themselves, you know, rather than afraid for their victim.
You're right. They're upset about getting caught. Not that having done something wrong.
Yeah, and that may lead to sociopathy in adults. Yes.
Makes sense. Now, how does conduct disorder differ from oppositional defiant disorder?
Well, the difference is that these children will actively defy rules by people in authority. They could be teachers or their parents, and the behavior will usually occur in common situations such as when they are told to get dressed or pick up their toys or go to bed, you know, or during meals. So, yes, they can be spiteful and vindictive, and they can throw tantrums. However, they don't show that kind of almost criminal type of, you know, activity that the conduct disordered child will have. It's a subtle difference, but there is, when you see them over and over again, you can detect the differences.
Right, or I'm sure just talking with parents or with the teacher in school, you could start to get a sense, can't you?
Yeah, and a conduct disordered child will be very charming at interview.
I'll bet.
Whereas the ODD child will annoy, you know, even the child psychiatrist. So,
the conduct disorder kid is charming at the first interview.
Yes.
But then get to know you, and he's going to play it out with you.
Yes.
Right.
Yes.
What should you see more of, conduct disorder or ODD?
Oh, unfortunately, I'm seeing a lot of conduct disorder, which is, yeah, it's very worrisome.
What kind of treatment is effective for ODD and conduct disorder?
Well, in the past, stimulants were widely used for any kind of disruptive behavior, and we found that they're actually not effective and may exacerbate the defiant behavior. Individual psychotherapy, group therapy, and family therapy is very effective. In my practice, what we do is if the child is setting fires, a lot of times we'll elicit the help of the local fire department. They'll talk to the children. The juvenile court system is often involved with conduct disorder. These children generally will be assigned a probation officer, and these probation officers actually track them down and make sure they're in school. They'll give them a curfew, and I've had several children respond to that. Plus psychotherapy, you know, we engage them. They get to talk to a therapist weekly, and the community outreach. You know, a lot of these kids will respond to going to karate class or, you know, channeling their aggression in a better way, more discipline, maybe Tai Chi or something like that.
You sound optimistic. You sound like positive about treating them.
We definitely can treat them once they're diagnosed, yeah. And
then the medication side, you said, what you've said is the psychostimulants are used too much and can actually exacerbate the condition.
Yes.
So what do you, once you figure out that you've got conduct disorder or ODD, what do you?
Clonidine at times can be used to decrease aggressive outbursts. There is a study by Dr. Malone where he used lithium in hospitalized children with a conduct disorder, and it helped their aggression. SSRIs are actually very helpful in decreasing impulsivity and aggression. And the kids then are a little bit easier to accept therapy and easier for their parents to deal with.
Okay. Good. Chuck, what about research for conduct disorder? What do we know from the evidence base about treatment?
Well, I might say that I am very glad to hear of Sharon's optimistic view about being able to make a difference in conduct disorder. Being a little bit older age group, I noticed that during my training, the idea that we would be able to make change in an antisocial personality disordered young person, our outlook was pessimistic. I think also that the use of medications in childhood disorders in this arena is somewhat newer, and Bob Findling and his colleagues at Case Western recently published in last year's Journal of the American Academy of Child and Adolescent Psychiatry a double-blind and placebo-controlled trial of risperidone in this group of conduct disordered youth. And on the next slide, we see the demographics of the young people who entered the study, and those blindly and randomly assigned to placebo or risperidone are not different. And actually, we noticed that this is a kind of pre-adolescent group. These are young people already suffering from the behaviors that Sharon so nicely described. The RAP, the RAAPP, their baseline score is listed there at the bottom and is not different between the two groups. And this is a rating scale that looks at aggression against people and or property. So we're really honing in on some of the aggressive behaviors that Sharon described. After random assignment to either placebo or risperidone, as we see on this graphic, during the early 2 to 4 weeks of the study, there's a reduction in symptoms on this RAP for both groups. However, as the study goes along, the impact perhaps of being in a clinic with the structure of the clinic and the hopefulness of outcome, after a while that begins to wear off and the placebo group returns nearly to baseline, while those assigned to risperidone continue to have sustained improvement up to the 10 weeks. Now, I'd like to stress that this is a rating scale for aggression against people and property, throwing things, hitting people, etc. I'm not saying that this is curative of the disorder, the medicine alone. Well, maybe we could move to the next slide. Even though the aggression against people and property was reduced, the clinicians who were blindly rating just their overall impression also shows that with the clinical global impression that the atypical antipsychotic medication risperidone is superior to placebo, and just generally how the clinicians felt the youngsters were doing. And then I think on our next slide we see a little bit about weight gain. In general, the medicine was very well tolerated in this group. Dosing was low compared to the treatment of psychosis. Yet there was some weight gain in this study. And so that by the end of the 10-week trial, there was an increase in weight for the risperidone group compared to the placebo group. And I think many of us who are interested in psychopharmacology of youngsters have to be aware of this weight gain across the board for these new agents. And you know, Sharon and I may talk a little bit later about differences in weight gain vulnerability for maybe especially the teenagers.
Right. But what I'm getting from the two of you with studies of adolescents and children is that the efficacy with these atypicals is really coming through. And that seems to be, whatever condition we've been talking about, the atypicals really seem to be an option to be using, really coming out that way.
You know, I might note here that many of the things that Sharon and I are talking about today are case series. The last study was placebo-controlled.
Yes.
And so that when we're talking about efficacy, it is random assignment, placebo-controlled, and the differences are not just from baseline, but compared to a placebo.
Right. We're not going to see much placebo-controlled studies in kids, are we?
No, parents are very hesitant in having their children, enter these studies. I mean, these are a lot of times very sick children that need treatment right away. And so they really don't want them on a placebo, and
tough to do.
You can understand. I want to just add one point to what Chuck said regarding seeing these patients when they get older and how pessimistic a view you have with sociopathy. And I agree. Part of my frustration as an adult psychiatrist was I wish I could have gotten to them when they were younger.
Right.
And the beauty of being a child psychiatrist and seeing these children and diagnosing them at the age of 4 and 5 and 6, you can kind of get to them before the criminal justice system gets to them or before it's too late.
You really have a sense of being able to impact.
Right there on the front line.
Yeah, good. So more positivity.
If I could just ask, this is a research project with risperidone compared to placebo that has nice statistical outcome. Are you using atypicals as part of your treatment regimen in adolescents with
Yes.
conduct disorder?
Yes, if there's a lot of aggression, yes, absolutely.
Okay.
Especially the ones that are sneaking out at night and disappearing.
Yeah.
I mean, it helps them sleep.
Yeah. Let's turn our attention, Sharon, to attention deficit hyperactivity disorder, or ADHD. What about recognizing and then treating that condition?
Well, these children are characterized by gross inattention and impulsivity. And I don't mean just like, once in a while spacing out. I mean that they cannot sit and listen in the classroom. They're getting up, they're interrupting, they're blurting answers out. A lot of times they're failing in school. They have no friends because they're always in other children's face and kind of intrusive, and they're not well liked. And generally, they have a stable mood. They're like a Dennis the Menace type kid. They're good kids, but, they just cannot sit still, and they're very frustrating to parent and to teach. Stimulants are the treatment of choice in ADHD. They're very effective, and there have been multiple studies that have proved this. Clonidine may be prescribed for difficulty with sleep, and actually bupropion has been found to be effective in adults, and I've used them in children, and I know many of my child psychiatry colleagues have used them. There are no studies on that yet, though. Stimulants also can be combined with the atypical antipsychotics if there is a comorbid mood disorder.
Now you're bringing up a topic, I think, that's gotten quite a bit of attention in your area recently. And I know you've been involved, actually, with some of the research. The idea that ADHD and bipolar disorder may be connected in some sort of a way. I mean, diagnosing bipolar disorder in an adolescent, I think, can be tricky. Tell us what you know about diagnosing juvenile bipolar disorder, and then tell us about this controversy about this relationship between bipolar disorder and ADHD.
Well, there actually is a debate in the literature, and it appears that some people don't believe that bipolar disorder even exists. However, I can tell you that it exists. I saw it in Boston. I see it in North Carolina. I mean, it definitely exists. This is the most impairing form of childhood psychopathology. These children are chronically irritable, dysphoric. They have an agitated mood. They have many horrible temper tantrums. Often they'll say they want to die. They have terrible nightmares when they do sleep, and many times they can't sleep. In their dreams, they often die, or they'll dream about a parent or someone dying. There are many psychiatric hospitalizations. And when you speak to the parents, you might find that there is a history of bipolar disorder, or there's been a relative that had erratic behavior, was jailed, or was alcoholic or drug addict, and may not have been diagnosed. And what makes the diagnosis tricky is that 60 to 90% of these children have comorbid ADHD. And actually, Dr. Biederman and his colleagues at Mass General Hospital were faced with a lot of this controversy, and they did a systematic structured interview and compared that with the child behavior checklist. And what they found was that using the empirically derived checklist and their structured interview, the studies came out, even. I mean, both were found to, that these children had bipolar disorder as well as ADHD. In the next slide, you can see that 16% did meet full criteria for mania. The clinical picture was characterized by severe irritability. Their presentation was mixed with mania and depression. And I think that's the trick. These kids aren't having spending sprees, and they're not promiscuous, obviously. Their way they show mania is a little different. They're destroying toys. I had a little boy who got up in the middle of the night, tore pictures out of the picture frames, sprayed the salt and pepper all over the refrigerator, destroyed, the kitchen, and while the parents were sleeping, So, I mean, it's different than adult mania, but it is still this agitated, aggressive, pent-up type of presentation with lots of dysphoria. Again, these manic children did meet criteria for ADHD as well.
So let me see if I understand it. Tell me if I'm right. When the study you did in Boston of bipolar disorder diagnosed kids, huge number had comorbid ADHD.
Yes.
Another study that you just showed us, when you looked at ADHD kids, there's a substantial proportion who are clear bipolars as well.
Yes, and Dr. Janet Wozniak did quite a few studies proving that.
Okay.
Yes.
So this, and it stands to reason. I mean, you have a hyperactive kid. What's the difference between hyperactivity and mania? And it stands to reason that there may be this kind of relationship that's been going on clinically. All right, now that's the phenomenology. Once we diagnose juvenile bipolar disorder, how do we treat it?
Well, first of all, let me say that mood stabilizers have been used. They have been very effective. However, their responses can be slow, and sometimes relapses can occur.
So if we talk about the atypical antipsychotics as what the topic of our program, one of the things that occurs to me is now that olanzapine has an indication for mania in adults, is that following through to your practice and child psychiatrists taking advantage of that?
Yes, it is. In fact, I participated in a study at Massachusetts General Hospital that was led by Dr. Jean Frazier, and we had an 8-week open-label trial using olanzapine in children and adolescents. Now, all of the children met criteria for bipolar I disorder, and they were either manic or mixed. We started them at doses of 2.5. And let me just say that these children ranged in age from 5 to around 12 years old. The next slide can show that there was a significant change from baseline to endpoint, and I can tell you that this change occurred almost immediately. We had children that hadn't slept for 2 weeks at a time.
Wow.
In fact, the 5-year-old in the study was my patient, and Mom brought him in. You know, she was exhausted herself, and she had bipolar disorder, and he was triggering her into mania because he was up all night.
This is the Young Mania Rating Scale that we're looking at here.
Yes, and they all showed improvement within a week. And this little boy, in fact, slept right away within 2 days, and he was able to return to kindergarten where he had been thrown out. And then the next slide will show that week to week, they significantly improved from baseline.
Wow, look at this drop here, initial drop that
Yes.
you were talking about. You really, this is palpable. You really see this response.
We were all very hopeful, when we saw that, and parents were very pleased. And so were the children. I mean, and that's a case where the children will say thank you.
I was just going to ask about acceptability. We see very nice reductions in symptoms. I think, Bill, you've already noticed statistically significant in the first week. But are youngsters tolerating this treatment?
Yes, they are. One of the main things, though, side effects that we did find was increase in appetite and some sedation. Now, the sedation, as I said, we wanted that. These are children that cannot sleep.
Nothing like a good night's sleep.
Right. So, of course, because that improves your mood, right?
Sure.
So anyway, the sedation was fine, and that generally wore off. Increase in appetite, that occurred in about 60.9% of the children, and that also occurred almost immediately. But we were aware of this from the adults, from using olanzapine in adults, and we were able to tell the parents and the children, that there would be some weight gain. Now, many of these children, because they weren't sleeping, they weren't eating right, and they had been treated with stimulants in the past, they were underweight to begin with and anorexic. So, not diagnostically anorexic, but they weren't eating. So increasing their appetite actually was a benefit to these kids. The next slide will show how the weight gain was very significant over the course of the study. We found that, though, generally it tapers off after about 8 months.
What time period is this that we're looking at? This is the 8 weeks.
Yeah.
So isn't this what you showed us also for the risperidone study?
It's really right in the same ballpark as was seen in the conduct disorder youngsters treated with risperidone.
Right. Interesting.
Over about the same time period, 10 weeks maybe.
And weight gain also occurs with mood stabilizers too, so I guess it's part of all of our treatment to date. In summary, olanzapine was very effective in improving the levels of mania, depression, and psychosis. The treatment was well tolerated. There were no changes in extrapyramidal symptoms. And as I said, body weight was increased over the 6 weeks.
Right. Let me pick up again on the weight, because we're going to be, in a little while, going to the phones and asking people to call in. And I would imagine people will call in if I don't ask you about weight gain in children. And clearly you're saying you see it. How management. Give us some ideas of how you and your practice are managing the weight gain issue.
Well, first and foremost, I tell parents and the child that there will be some weight gain. Now, as I said before, many of these children have comorbid ADHD. And so once we get their mood under control, I initiate stimulants. And the stimulants actually balance out the weight gain, because one of the problems with stimulants is that the children are not eating. So we give the stimulants in the morning, and we give olanzapine at bedtime. And so once the stimulants wear off, the olanzapine's on board, the children will eat. And even if they eat a lot, it balances it out. So in those children, I don't have a problem. With children that aren't on stimulants and don't have ADHD, the parents are just so happy that their mood is better that they go with them and are able to, kind of be with them more. And they many times will do, go swimming together or walk or their bike ride. And generally, both parent and child are much happier. So they're willing to do exercise and to, watch what they eat and all.
So what's the bottom line for what we've covered today on bipolar and other disruptive behavior disorders in children, adolescents, and young adults? How would you summarize it?
I can't stress this enough, that proper treatment depends on the correct diagnosis. I think that is the most important take-home message, that not all disruptive behavior is ADHD, not all inattention is ADHD, that there are many diagnoses that have to be ruled out. Once you have the correct diagnosis, treatment goes from there.
Boy, I'll tell you, you sure have impressed me with how important it is, and also taught me. It's been a while since I've been trained in childhood disorders, so it's very useful to run through that, and you really made it clear how important that is to know what you're looking at.
Thank you.
Chuck, the last time you were here, you presented work you've been doing in the treatment of borderline disorder, which borderline disorder, you can see some connections to these childhood disorders. You've got disruptive behaviors, emotional lability, and so forth. You were showing us data with atypical antipsychotics in borderline personality. What's new since you were last on? Any recent developments?
Well, Bill, thanks for remembering that. That's very gratifying. Let me work back from adults a little bit. Over the years, I've been interested in antipsychotic treatment for patients diagnosed as having borderline personality disorder, frequently also comorbid with schizotypal personality disorder. The traditional antipsychotic medications are efficacious compared to placebo, but the tolerability of these medicines in adult borderline personality disorder patients is quite low. My experience generally is patients saying, yes, this medicine has helped me, when can I stop? When the atypical antipsychotic medications came out, our group was fortunate to receive some grants to study these new medications in this group of patients. We have a slide here about a poster I presented at American Psychiatric Association annual meeting year before last, taking a look at 31 patients with borderline disorder over an 8-week study. We also studied this with patients for a year or two after the study was over. And we found that risperidone led to substantial reduction in symptoms, but that the patients blindly and randomly assigned to placebo also made improvement in our personality disorder research clinic. And I'm going to cycle back to this placebo response question in a moment. Our follow-up indicated that many patients on 1 or 2 milligrams of risperidone did very well. Over the long term, occasionally depressive episodes would occur, and risperidone and SSRIs were useful for these people. Well, olanzapine was then introduced, and because of the data demonstrating the impact on depressive symptoms during the treatment of schizophrenia, we wanted to study olanzapine on borderline disorders, but in a more real-world way. And so we included people who also had dysthymia. We used the same sort of relatively short interval to study, as can be seen on our next slide about olanzapine. And we we designed our study for the short term because these medicines had not ever been tried in personality disorder patients, and we wanted to understand the dose and the tolerability. What we saw in a study we published in the Society of Biological Psychiatry journal in 1999 is that symptoms as assessed on the Hopkins Symptom Checklist 90 went down briskly in this group. Surprisingly to me, 9 out of the 11 patients in this case series finished the entire study, and only 2 of the 11 decided to stop before 8 weeks, and one of those probably because of a relatively slow titration of the medication. So our group was pretty enthusiastic about the potential role in some borderline patients for the atypicals.
Mm-hmm.
You know, the next slide will extend the 2 things that I've been talking about, and Dr. Zanarini and Frankenberg have just completed a study that I think is very nicely designed and takes into account some of the problems with our preliminary work. They decided to look at olanzapine in a placebo-controlled study that I think is of sufficient length compared to the 8-week studies that we had done. We know that borderline disorder is a persistent maladaptive interpersonal relationship disorder, and it doesn't just go away. And so this 26-week study addressed borderline patients using the Hopkins Symptom Checklist and some other rating scales as endpoints. And if we go to the next slide, we see some very interesting results. Hopkins Symptom Checklist 90 went down substantially more for the olanzapine group. And if I could direct your attention to about the 4th and 5th lines down, expectedly, psychoticism and paranoia are reduced. And that's kind of our old idea that the antipsychotics are treating psychotic-like problems. But you know, if you look around, anxiety is reduced maybe even a little more than paranoia. Interpersonal sensitivity, as assessed by the Hopkins Symptom Checklist 90, olanzapine was superior to placebo. And so there's a broad number of symptoms that are reduced by olanzapine in this borderline personality disorder group.
And an increase in the GAF score. Clinicians use the GAF a lot. That's a substantial increase. I mean, this is a clinically significant efficacy that you're showing us here.
Well, I think this trial really does show that in addition to psychosocial interventions, that the atypical antipsychotic medication can add to a reduction in feelings that a borderline patient is having, but also functioning. And we had GAF increases with olanzapine in our case series and risperidone in our double-blind trial, going from the low 50s to the high 60s. There is a substantial change in these patients. Mm-hmm. Now, I'd like to say maybe a closing word about this study about addressing tolerability or side effects. We've been talking a little bit about weight gain as we've gone along with our program here, and we see in this slide that there was a weight gain that was higher than was seen on placebo, and there was a little loss on placebo actually. But you know, when we were trying to move from the traditional medications, and we would like to make sure these medicines are tolerated, no akathisia or tardive dyskinesia reported by these authors. They say one subject in the olanzapine group developed some rigidity. In our olanzapine study with 11 subjects, the relatively slow month-long titration of doses, we saw no rigidity, and this group says no other EPS was noted.
Yeah, I'm kind of looking at the what is a lower weight gain. I mean, relative to the other weight gain slides we've been showing today. Mm-hmm. It's interesting. Mm-hmm. Interesting. Different diagnoses perhaps might show different responses here.
Well, just speculating. I think there may be differences in diagnoses. There may be differences in age groups. I know that people are taking the results of some of these early studies, and when they're seeing repetitive self-injurious behavior, substantial impulsivity, and other borderline symptoms, beginning to try atypical antipsychotic medications in teenagers. in lecturing and visiting around the country, a number of people have said they've been trying olanzapine or risperidone or quetiapine in a little bit younger age group. But I'm not aware of any published case series or research projects to look at these behaviors in youth. In youth, meaning the adolescent group, if you will, we know that these are youngsters for whom, when they're on no medicine, I've had 2 teenagers myself, and you know, you're almost locking the refrigerator during normal adolescent development. Then you are giving medicines that may remove a sensation of being able to feel full. And so age as well as diagnosis may be an important factor.
I've often said I think adolescence is a diagnosis.
Well, I'll debate you on that one. I think, because I think, and the reason I said I debate you on that one is that because of the impression that adolescence is really a time of abnormal feelings and behaviors, we have been slow to detect early stages of bipolar illness, early stages of schizophrenia, cognitive disorder, and oppositional defiant disorder. Most kids aren't having these problems.
Right, right. Okay, let's pause at this point. I'd like to invite you, our viewers, to call in with questions or comments that you might have. The number to call is 1-888-533-2786. And I just want to say we've had many requests over the years for a PyschLINK program that targets the adolescent and child population. And I'm very interested to hear what you're doing in your own practices, and if there are further questions that you'd like to have answered in this area. Now, while we're waiting for those calls to come in, Chuck, I want to start with you, and Sharon, if you want to come into this discussion, feel free. What we've been talking about, we've focused in on the atypical antipsychotic medications. We've talked about their use in a number of different conditions in children and adolescents. And you've got into borderline, which starts getting even a little older group. What are the atypicals treating in the non-psychotic conditions?
Well, my impression about what we've been observing, other people have been observing since these new medicines came out, is that they're treating a broad spectrum of psychopathology. The ideas during my training that the antipsychotics for the psychotic disorders, the mood stabilizers for mania, the antidepressants are only for depression, and that we're almost in a one neurotransmitter, one disorder mentality, just doesn't seem to be true. Just think about what we've heard today. Atypical antipsychotics helping with mood symptoms in both directions, anxiety, aggression, impulsivity, really a pretty broad group of symptoms. I think the interesting thing, or next step after this, will try to be to understand, how is this happening? Is this because we're treating perhaps a broader group of treating or blocking different receptors? Is it because the medicines perhaps also reduce stress and anxiety, and that may be driving some of the abnormalities that we see in mood or psychosis? I think these are some of the exciting questions that we might look at next.
It's a very interesting area, I think, that's opening up here.
Yeah, I think so too.
Another disorder that I've had some success with is Tourette's. It's, you know, it's not a psychotic disorder, it's actually a movement disorder. However, children are responding, and I think your point about it decreasing the anxiety, because once the anxiety is decreased, then the tics will decrease.
Right.
So I've used it in that, you know, major depressive disorder with psychotic features.
You see a lot of that in kids, huh?
Yeah, in fact, you'd be surprised how many times depression is missed, especially in the schools, because the kids who are depressed are generally the good kids. They're not a behavioral problem. You know, they're sitting in the back, they're quiet, but, you know, they're having thoughts of suicide and maybe hearing, you know, hearing voices.
Okay, phone calls are starting to come in, and we have actually, our first question has come from the internet, and I'll read it to you. In treating the child and adolescent population, is there concern about prolactin elevation? It's a good question. It's something we haven't covered today. Who wants to take that?
I'll take it because actually it is a great question, and yes, I'm actually very concerned about that. We're not sure how prolactin elevation would interfere in normal growth and development. If I have a child on a medication that would increase prolactin, I always get a baseline level and watch that because, as you know, with elevated prolactin levels, there can be galactorrhea, abnormal breast growth. This could be devastating to children. So, I tend to avoid using anything that's going to interfere with normal development and interfere with the hormonal system.
Well, I'd sure like to say hi to Dr. David Ross at Central State Hospital.
You sneak.
I think was a med student when I was at Medical College of Virginia. Hi, David.
And he's the first in line of 6 people that are waiting to ask us questions. So did you want to comment on prolactin?
I would. In addition to saying hi to David, I would say that in our work with young people, prolactin elevation does lead to difficulties like galactorrhea. But in our young adult population, this sort of relationship between sexual side effects or prolactin-related side effects seem a little less rare. And so we're maybe feeling our way through prolactin increase with the atypicals.
Right. Although it seems to me if you can avoid it,
or at least monitor it.
Right.
At the very least.
Watch out for it.
Definitely take your baselines.
Right. All right, let's go to Dr. Schultz's friend, Dr. David Ross at Central State Hospital in Virginia. Welcome to PyschLINK, Dr. Ross.
Thank you, Dr. Glazer. I'd like to say hi to Chuck as well, and who's my former teacher at the Medical College of Virginia. I enjoyed your presentation today, and my question is about the use of methylphenidate in children or adolescents who may have bipolar disorder and/or attention deficit disorder. And the question is it possible that methylphenidate could result in kindling of a bipolar disorder, and what would be the implications for treatment of our patients if that would be the case?
That's a very good question. Actually, the way I handle that is, as I said before, correct diagnosis leads to correct treatment. So the first thing to do is make sure the diagnosis is ADHD and not bipolar disorder, so that, if it is bipolar disorder, you would go to the mood stabilizers first or the atypical antipsychotics. Once the mood is stabilized, then you can begin treatment with the stimulant for attention problems.
What about the kindling idea? Is that
I'm not quite sure about that. I don't know about the studies on that, so I really can't say. It would make sense. We do know that giving a stimulant to a child with bipolar disorder does worsen it. Mm-hmm. So, perhaps perhaps it can trigger it if it is already there. I'm not sure.
Okay, interesting.
But I would go back and say it really, David's question underscores the importance of diagnosis. Diagnosis first, because if you're using methylphenidate or other stimulants in a person who may have a propensity to having a manic episode, then this phenomena of kindling may then speed up or hasten the onset of mood disorder.
And also, I'd like to add a very important point. Many times the children may be seen by not necessarily a child psychiatrist or even adult psychiatrist, and the children may be given a prescription for Ritalin and then not seen again. Maybe the parents are picking it up or it's mailed. I think careful monitoring, Ritalin's a very safe drug, but you still have to monitor and see these children so that if something did come up, and they were to become manic, you're there and you see it, before it gets out of hand.
Good. Okay. All right, a lot of phone calls, and I'm remembering David Ross now myself, having visited, and when I met him, I knew that you had trained him. He was so smart. Dr. Nelson, now this is Eastern State Hospital, which I'm going to guess is Virginia. I'm not sure. Welcome to PyschLINK, Dr. Nelson.
Hi, this is the state of Washington.
Okay, great.
I do want to ask another question on prolactin elevation. Risperidone predictably elevates prolactin, about doubles it in young males, say 10, 12 years of age. It may also lower the testosterone. What's that going to do with secondary sexual development, and do we need to include that in terms of informed consent?
I think that you were speaking to that, but now let's up it a bit.
Informed consent. Absolutely. If I'm going to use a drug that would change the body chemistry in any way, I do work with the parents. As a child psychiatrist, parents are your partners. You really don't do anything without discussing everything in detail with them. So that's.
But in fairness, though,
with anything that's going to elevate prolactin.
Yep.
The patients that have come to me on this already, I do inform the parents, and we check the prolactin levels, and I let them know it's a concern. We don't know what's happening.
Okay, that's what the point I wanted to make.
It is a concern.
In fairness, we need studies fast.
Absolutely.
On this.
Yes.
Because Dr. Nelson's raising a very important question that can be studied. The impact, it lowers testosterone and it lowers estrogen, and then what's that doing to sexual development, bone development, etc. So, good, we're getting in the endocrine system well today. Back to the phone lines. Dr. Sharma, Happy New Year, Dr. Sharma, calling from Larned Hospital in Kansas.
Happy New Year, Dr. Glazer. This has been so excellent talk. Thank you very much again.
Thank you.
I have a question. You people talked about olanzapine and risperidone, and sure that is a weight gain is a big problem in this adolescent group. And you start at a low dose and go slow. Once the patient is stable, and then you end up seeing the weight gain problems. Do you have any experience at that point augmenting olanzapine or risperidone with either Wellbutrin or quetiapine, so which can take care of the weight gain problem?
Could I, before you go, if you don't mind, it sounds like you might have an observation on that, and we'd be interested to hear what you think.
Well, I do have some experience with using those medications. I think augmentation is a big goal in achieving because the side effect of quetiapine and Wellbutrin is weight loss. So at that point, when the patient is sufficiently stable on olanzapine and risperidone, and then if you discontinue the medication or decrease the dose, then patient go into relapse.
Right.
So at that point, we have to think about augmentation. So I'm thinking that these two medications is the best choice at that point.
Okay, thank you. Thank you for that observation. Either of you have any thoughts on this?
I tend to, if the mood is stable, I will generally not change anything because that's really what we were, hoping for. I will go after the weight gain in other ways, such as diet and exercise, rather than change the medication. I tend not to like to add so many more medications, to treat the symptoms and side effects.
Anecdotally, we've heard of some of the anti-ulcer, anti-acid medications, H2 blockers.
Right.
Have you used those in your practice?
Actually, that's relatively new. I actually just heard of that too, and it sounds promising.
Yeah.
I haven't used it myself. I've used very little of topiramate. Yes, I have used bupropion. Especially if there is a comorbid, depression or depressive mood, sure, I would use bupropion.
And I think it's important to point out that Dr. Sharma's observations, I think he's working with adults. At Larned State Hospital, I think he's working with an adult population, whereas your caution about this with children and adolescents just kind of goes along with the theme of our program today. So I think that's important to say. But I think this year, from what I can see, we'll be seeing some studies on H2 blockers and how they are helping out with the weight gain issue. So stay tuned to that. We have a call from Dr. Mike Nash in Anaconda, Montana. Welcome to PyschLINK.
Well, thank you very much. We've enjoyed the program. Our question is whether there has been any experience with the use of the atypical antipsychotics with the dual-diagnosed cognitively delayed or mentally retarded population, for particularly where severe aggression is involved.
Okay, good. Aggression is a target behavior.
Do you want me to? That's actually a great question, and yes, absolutely, I have used it in children who are mentally retarded and are aggressive and have outbursts, and I found very effective. How about you, Dr.?
Treatment center associated with University of Minnesota, where one of our clinical faculty, Dr. Fred Farron, is using the atypical antipsychotics for the aggressive or agitated behavior in the developmentally delayed or developmentally deficient group. From what I've heard, in addition to what we might have expected to see with traditional antipsychotic medications, the atypical agents appear to be superior in this area. And of course, your research background in tardive dyskinesia, we know that youngsters can end up on medicine for a substantial time and are probably at high risk for the development of tardive dyskinesia. So the new medicines do offer some promise.
Right. I've looked at the literature for atypicals in aggression in schizophrenia. I'm not sure I've seen much in mental retardation per se, but from what I've seen in schizophrenia, I'm a believer. I think that the atypicals are just obvious class of drugs to use for aggressive behaviors in this population, because the mentally retarded population is so susceptible to movement disorder, EPS effects, and so forth. What I found in my review of aggression in schizophrenia is that all three first-line atypicals, Risperdal, Zyprexa, Seroquel, have anti-aggressive effects. It's interesting with Risperdal, when you look specifically at aggression, your doses of Risperdal in studies are usually at 6 milligrams or more. So it's higher doses. The olanzapine studies, the early ones that I have been able to find, are coming in, I think, between the 5 and 20, but there's a suggestion that you might see elevations there. I'm less clear with the quetiapine. You may know better, Chuck. I think that the studies of aggression with quetiapine have stayed within the labeling for dosing.
Well, they've stayed within the labeling, but I think we also need to remember the sites and the samples of where some of these studies have been done.
Right.
And whether they've, I think Dr. Peter Buckley, when he was at Western Reserve State Hospital, took a look at atypicals in an aggressive group of psychotic patients in a state hospital, Young Volavka in New York. They're working with a group of very severely ill patients, and the increase in dose may be related to trying to handle aggression, but may also be part and parcel of trying to handle a severe spectrum of the disease.
Right. The Department of Mental Retardation has been against antipsychotic medications around the United States, trying to diminish its use. I personally think the atypical antipsychotic medications should open that door. And I hope that there's movement in that area, because I think there's real treatment opportunity there.
Good point, Bill.
Dr. Nihar Saha, calling from Middle Tennessee in Nashville, Tennessee. Welcome to PyschLINK.
Thank you. I really thank you all for, we enjoyed this nice talk. I'm personally interested in the treatment of autism for a personal reason. I heard you all talking about traditional treatment, but there has been some talk, even in the news media, about treatment of autism with secretin. So I want to know your opinion, latest information about it.
I'm sorry, now, treatment with what?
Secretin.
Treatment of autism with secretin.
Secretin, okay. Do you know anything about that?
I'm familiar with it. They tend to feel that autism is sort of a malabsorption syndrome, and there have been some studies whereby they use secretin or they use large amounts of vitamins in order to help this malabsorption syndrome. I don't know that much about it. It's not something that obviously that I would use as treatment. I think experts in that field would probably be pediatric gastroenterologists and
Well, either that or autism being is so difficult, as Chuck mentioned earlier, to treat. I think we start to see desperate efforts in many directions, and I get emails a lot, news about this. I hadn't seen the secretin. I'm not an expert in this area, but this always concerns me, because you get this gnawing feeling. Does it work? And there aren't any studies. It's observations, and it's such a difficult disorder that autism just screams for these different treatment approaches, and it's hard to evaluate.
Well, I have one mom who found that every time she gave her daughter antibiotics for ear infections, she seemed to get better. And she wants her pediatrician to initiate antibiotic treatment, and it's something that's not been done. And so these are areas that haven't really been studied, and everyone is searching desperately for treatment.
Right. We've tried to present the evidence base that we have available to us. We chose the atypical antipsychotics in this show, but certainly there are other options, particularly in a disorder like autism. I hope that's of some help.
Well, if I could just add one thing, it also speaks to really, despite our enthusiasm for what we presented today, for all of the things we've discussed, we're talking about symptomatic reduction. That we still need to remind ourselves we don't know what autism is. We don't know what schizophrenia is, and that we're reducing symptoms with less side effect and treating a broader array of symptoms. But when you have a disorder like autism, you really don't know the pathophysiology. There's probably going to be a broad group of things tried.
Yeah, I suspect you're right.
Early diagnosis and early treatment with socialization, occupational therapy, rehab, the school system getting involved, those are actually help the prognosis.
Okay, good, thanks. All right, back to the phone lines. Thank you for your patience, those of you who are waiting on the phones. This is a great response. And by the way, there's still time to call in, I think. I'm not sure how many people are waiting, but the number to call is 888-533-2786. We have a call from Carla Jeter, who's a farm tech at a VA medical center in Dayton, Ohio. Welcome to PyschLINK.
Thank you. I also was calling because I have a grandson who has been diagnosed with autism, and he is 3 years old. He is currently on olanzapine 2.5, and I must concur with the doctor that the immediate results were there when he started on the 2.5 at bedtime, because he was head banging, screaming, no sleep, and it just went away, the drowsiness and everything. The only thing is that he had suffered from constipation there. Okay, but during a period of time before he went to sleep, he's been on there 3 months now. Before he goes to sleep, he runs to and fro. He's just hyped, like someone just attention deficit, or I can't think of the thing right now. I'm just so excited because I'm very fascinated with this.
Yes.
And the other thing is that he was without it for 2 days, and immediately those symptoms returned. He would just hit his head and everything. It just started all over again.
Well, thank you, Carla, for calling in, and best wishes and best luck with him. I hope that we continue to find these kinds of improvements. Let's hear what our experts have to say in response to what your observations are.
I've actually heard this from other parents, and generally what I do is during the time that they're running around, I'm wondering if it's before the dose is given. I suspect it's not. So I would give the dose earlier, around 6:30 or 7 o'clock at night. Also, they seem to break through the dose. 2.5 is very, very low. So after 3 months, he may need an increase. So what would I do then is I would instruct mom to give him 2.5 around 6:30, 7 o'clock, and then the other 2.5, if she wants him asleep by 10, then give it at 8:30.
And I'm just imagining having a new grandson. What a improvement it must be for him to be able to sleep. And while it's not, as Chuck said before, we're not talking about cures for autism. To have something like that is very nice to hear. The success with that medication.
Especially the improvement with head banging. I mean, think of the brain damage with that alone. I mean, it's really significant.
Right. Okay, back to the phone lines. We got a call from down here in Texas. Dr. Douglas Johnson from Big Springs Hospital in Big Springs, Texas. Welcome back to PyschLINK, Dr. Johnson.
Well, thank you, sir. I'm interested in whether any of you have experience with combining lithium, clonidine, SSRIs, either 2 of the 3 or even all 3, in conduct disordered children who are repeatedly destructively aggressive.
Actually, I have. I've used SSRIs with olanzapine without any problems. Clonidine at times, if in the daytime they still remain irritable and aggressive. And And what was the third?
Well, there was, I think you
lithium.
mentioned lithium, clonidine, and SSRIs.
I haven't had to use mood stabilizers. Once I use olanzapine, it appears that stabilizes the mood. So I haven't had to add a mood stabilizer. What I would do is increase a dose before I added another, mood stabilizer. But I have added, as I said before, I've added stimulants when there was attention problems. If there's depression, I'll add an antidepressant. And again, I start very low, and I tend to give the Zyprexa at night and the other drug in the daytime.
Is conduct disorder one of those conditions that's likely to have multiple medications?
I'd say bipolar disorder with ADHD would be top. With multiple, polypharmacy, and with conduct disorder, again, with more therapy and more, kind of parental guidance and outside treatment.
Right. Okay, good.
Could I maybe say a philosophical thing about the question and Sharon's very nice response? I think during the time of my training, using the phrase polypharmacy or thinking of using two medicines at once was considered, inappropriate way of approaching a problem. When we look at other branches of medicine, hypertension, arthritis, etc., cancer therapy,
sure,
polypharmacy is common. And so I guess I'd like to split apart polypharmacy from the idea of a youngster walks in the door and you start all three medicines at once, and from the idea that you might start with a medicine in an aggressive conduct disorder person, whether it's a SSRI or lithium, Depakote, or olanzapine, and then seeing how things go. Mm-hmm. And then if there are other symptoms left to treat or response is not good, then you might consider moving on from there. And
kind of carefully watching step-by-step responses. And
so we don't think of polypharmacy as necessarily a bad thing when done in a responsible fashion.
Good, thank you,
Excellent
Chuck. But that's the ballpark, I think, with some of these conditions that we're in. I think we have time for one more call. Dr. Charles Murphy, Cherokee Mental Health Institute in Iowa. Welcome to PyschLINK, Dr. Murphy.
Hello. I'm wondering about the patient that has comorbid bipolar disorder and ADHD. Would you still use stimulants in that case? You mentioned methylphenidate as possibly being a trigger and something that you wouldn't use.
Let's go. That's good. Thank you.
Yes.
Let's take this opportunity to clarify again this issue.
Actually, I do use it, but I use it after the mood is stabilized. I'll start treatment with the mood stabilizer, and we're talking just in a few days or a week's time, just as soon as the child is sleeping and calm, then I'll start, a stimulant. I'm actually having great success with the long-acting stimulant, the new form of methylphenidate that's given over 12 hours. So these children now only have to take one medication in the morning, their stimulant, and then one at bedtime. So, and it's working quite well. I haven't had any adverse effects or anything, and moms are very happy with it.
What I wanted to I want to make sure I've got this straight. The point that I think I learned from you, and this is your work with Dr. Biederman and the group at Mass General, was that bipolar disorder in children is often associated with comorbid ADHD, so that the use of mood stabilizer, atypical antipsychotics, specifically olanzapine is where the data was and the indication, and then stimulants would come in for the ADHD part.
Yes.
And what you're saying is treat the bipolar part first, and then the ADHD. But then the other point I heard you make was that if you misdiagnose the patient and just use a stimulant alone, and there's bipolar disorder present, you might exacerbate the mania. I think if I understood you correctly.
Exactly, because you're not controlling the mood, and so the children are wired, they're awake, they're not.
And that's been the problem in practice overdiagnosis of ADHD, overuse perhaps of the stimulants, missing the bipolar disorder.
Yes, and the problem is they'll label it bad ADHD. Then these children finally will come to a child psychiatrist.
Okay.
Usually they're treated, elsewhere, and then they come and say, "There's no matter what we do, the stimulants do not work."
Okay, good. Well, believe it or not, that's all the time we have for questions, and we are out of time. Join us again on February 7th for Utilizing Cholinergic Therapy in the Treatment of Alzheimer's Disease and Other Dementias. We close today's program on a sad note. If you watch PyschLINK at one of our regular sites or at one that has just joined our network, then you've probably felt the influence of IMN's Rachel Birmingham. Rachel was responsible for registering sites and supporting the site coordinators who make your viewing experience possible. On December 27th in 2000, Rachel died in a single car accident. And this is the first PyschLINK of 2001. We'd like to dedicate it to her. Rachel operated at a grassroots level, making PyschLINK accessible, and by building and nurturing real human relationships with our loyal audience. She'll be remembered for her professionalism, and she'll be missed for her friendship. Thank you, Rachel.